The next symposium will update us on the latest knowledge on colorectal cancer. To chair this session, we have Dr. Yasantha Ariratna and Dr. Sajivani Jayawardena, consultant clinical oncologists, with us. Over to you.
Good morning, everybody. It's my pleasure to introduce the first speaker, Dr. Chinthaka Appuhamy. He's a consultant radiologist, MD, FRCR, and he started his career in medicine from the Faculty of Medicine, Colombo, and has had an illustrious career there with fellowships including vascular interventional radiology in Singapore and neurooncology radiology in Singapore and general radiology in India. And he has been responsible for a chapter on protection devices in endovascular practice in the Yearbook of Vascular and Endovascular Surgery. Over to you.
Hello, good morning. I'm Dr. Chinthaka Appuhamy, and I would like to present about the role of MRI in colorectal carcinoma. Once again, I would like to thank the Sri Lanka College of Oncologists for the invitation. MRI is the most accurate tool for the local staging of rectal cancer. MRI has certain advantages over CT scanning. Superior soft tissue contrast, which enables the identification of the different layers of the bubble wall, as well as identification of the peritoneal reflections. Multiplane imaging is possible without moving the patient. This diagram clearly illustrates the surrounding structures of the rectum. The thin green line demarcates the mesorectal fascia. The content within is mesorectal fat and the rectum. So any growth in the rectum, we need to be specified and clearly differentiate and assess the involvement of these layers in order to arrive at the proper staging so that patient can start with a proper management plan. This is an axial T2 weighted MRI sequence through the mid-rectum, where you can see the surrounding mesorectal fat and lined by a mesorectal fascia, which is illustrated and marked in yellow arrows. And it is usually thin and regular and hypointense. In males, seminal vesicles and prostate are the anterior relations, whereas in females, the cervix and the uterus are the anterior structures. The rectum broadly divides into three levels: the lower rectum, mid-rectum, and high rectum. The importance of this is the peritoneal cavity and the peritoneal reflection comes as anterior relations in mid-rectum, whereas in high rectum, the peritoneal cavity demarcates the anterior as well as the lateral relationships. Again, this sagittal diagram illustrates the three levels of the rectum. The lower rectum from the anorectal angle up to 5 centimeters. And the next 5 is mid-rectum, where the peritoneal cavity is the anterior relation. And again, the high rectum, the peritoneal cavity comes into play. The staging of colorectal carcinoma. The T1 disease, as you all know, it is confined to the submucosa, whereas the T2 disease, the muscular layer is involved. So there is infiltration into the muscular layer. However, it is confined to that area. So anything beyond that, then we stage it as T3. I will go into details about that. Lastly, T4 disease. The T4A illustrates the infiltration of the peritoneal reflection, whereas T4B shows the infiltration into the pelvic structures. In T3 disease, the MRI is very important. T3 tumors grow through the external muscularis into the surrounding mesorectum. As the rectum does not contain a serosal layer, tumor invades directly into the mesorectal fat and can spread to lymph nodes and beyond. T3 tumors are further differentiated in T3A, where the tumor extends less than 1 millimeter beyond muscularis propria. T3B, tumor extends 1 to 5 millimeter beyond muscularis propria. And when it involves 5 to 15 millimeter, we call it T3C. Anything beyond 15 millimeters, we call it T3D. When the mesorectal fascia is not involved, that means no tumor within 1 millimeter of MRF, we call it MRF negative. And MRF positive when the tumor is seen within 1 millimeter of the fascia. Midrectal tumor. This is a clear diagrammatic illustration of this axial T2 weighted image showing tumor infiltration into the mesorectal fat. In this case, it extends up to 15 millimeter, where you can see hypointense tumor stranding marked by the yellow arrow. However, the mesorectal fascia is not involved. When there is involvement of the mesorectal fascia, as I told you earlier, we call it MRF plus. So this T2 weighted axial sequence illustrates the involvement of the mesorectal fascia as marked by the yellow arrow. T4A, invasion of peritoneal reflection. This coronal T2 weighted image shows the peritoneal reflection as this tiny white arrow, and there is a hypointense tumor infiltrates into the peritoneal reflection. So this is really important when it comes to the surgical management versus neoadjuvant chemoradiation. Only the MRI can clearly demonstrate this involvement. In T4B disease, as I discussed earlier, the tumor infiltrates into the pelvic organs. In this sagittal T2 weighted sequence of a female showing infiltration of the uterus, so that you cannot see the fat layers between the uterus and the tumor. Then we call this as T4B. Extramural vascular invasion is another entity where you see infiltration of the tumor into the adjacent blood vessels. So these things can be seen as serpiginous, dilated structures, both within the mesorectal fat as well as beyond the mesorectal fascia. What's the difference between the CT and MRI? The left-hand side, contrast as CT, shows a tumor in the rectum with possible infiltration into the base of the bladder. However, in the same patient, when we did the MRI, we can clearly differentiate the base of the bladder from the tumor. So that's the importance of the proper MRI imaging for the clear differentiation and staging of the disease. MRI on nodes. Like CT, MRI relies principally on size to differentiate benign from malignant lymph nodes. Again, using a maximum short axis diameter of 10 millimeter. So in lymph node stage, the suspicious nodes has some basic malignant characteristics. The indistinct borders, where the borders are irregular, and the intensity within the nodes is heterogeneous. And as we all know, the lymph nodes are oval in shape. However, in malignant infiltration, they are rounded. So we can further categorize when the short axis is less than 5 millimeter. If we have all three malignant characteristics, we take them as suspicious nodes. When the short axis is 5 to 9 millimeter, we need at least 2 malignant characteristic features. But again, if it is more than 9 millimeter, we always consider them as suspicious nodes. So the end stage, the nodal stage, a node is no suspicious lymph nodes. N1, 1 to 3 suspicious lymph nodes, and N2, when there is 4 or more suspicious lymph nodes. This T2-weighted sagittal MRI image shows multiple, enlarged, rounded, and ill-defined lymph nodes within the mesorectal fat. When we see these chains of nodes, they are always suspicious, and you need to grade them properly. This is another example, T2-weighted axial image showing and rounded enlarged lymph node in the right lateral wall. Again, this small closed window shows a DWI image where there is restricted diffusion. In diffusion restriction, you see it as high signal intensity in DWI. So DWI imaging is again very important to differentiate malignant nodes from benign. Again, this yellow arrow demonstrates extramural vascular invasion. So MRI can be used to justify preoperative chemoradiation. When we see the following entities, such as CRM positive or threatened, then T3B tumors with more than 5 millimeter spread into perirectal fat. And when the sphincter complex is involved, and when there is extra mesorectal nodes and adjacent organ invasion, then the invasion of the anterior peritoneal reflection in upper rectal cancers. These two images shows the pre-chemoradiation, neoadjuvant chemoradiation, and the right side, the post neoadjuvant therapy imaging. The left side image shows large polypoidal mass with infiltration of the muscularis propria and infiltrating into the adjacent mesorectal fat. Whereas in the right side, there is marked reduction in the size of the node, the tumor. Again, T2-weighted imaging and contrast is vital to differentiate from fibrotic changes from residual tumor. The same patient, the coronal images shows large polypoidal growth in pre-treatment versus neoadjuvant chemoradiation post-treatment images with clear shrinkage of the tumor in the left lateral wall. So the tumor regression grades. Grade 1, when there is no evidence of treated tumor. Grade 2, good response, that is dense fibrosis with no obvious residual tumor. Grade 3 is moderate response, more than 50% of fibrosis or mucin and visible intermediate signal. We call grade 3 when there is slight response, that is little areas of fibrosis or mucin, but mostly tumor. Grade 5, no response, when there is no difference between pre and post-treatment imaging. MRI is again useful to detect colorectal metastasis, particularly the liver. Lesions that are moderately hyperintense on T2 weighted images and hypointense on T1 weighted images. T2 weighted images tend to show metastasis as having an ill-defined margin with slightly low heterogeneous signal, and also they may appear as target lesions with central high signal and adjacent low signal corresponding to compressed hepatic parenchyma. This coronal T2 weighted MRI sequence of the liver showing ill-defined, hypointense multiple lesions in the right lobe of the liver. Sometimes it is difficult to detect these lesions in CT because of the hypovascularity. However, because of the multiple sequences we have in MRI, MRI is sometimes very much superior compared to the CT. This is another example of axial T1 weighted post-contrast fat-sat images, which shows ill-defined, hypointense, large focal observation in the right lobe of the liver. In conclusion, high-resolution T2 weighted images are the cornerstone for staging of primary rectal cancer. Superior soft tissue contrast, which enables the identification of the different layers of the bowel wall, as well as identification of the peritoneal reflections. MRI is invaluable in further differentiating T3 tumors, which helps in neoadjuvant chemoradiation. Other than the size, the malignant characteristics of the lymph nodes are well demonstrated in MRI. Again, MRI is very useful to detect colorectal metastasis, particularly in the liver. With that note, I would like to conclude my presentation and thank you very much.
Thank you very much, Chinthaka. It has been a very valuable information for all of the oncologists here. And I have a question which have been sent to us. And this is apart from the T2 sequence, how important are the other sequences in the staging of the rectal cancer? I hope you got it. Apart from the T2 sequence, how important are the other sequences in the staging of the rectal cancer?
As I mentioned in my presentation, DWI and ADC values are very important because the malignant lesions and especially the lymph nodes. Can you hear me?
Yes, of course. Please go ahead.
So there is restricted diffusion in DWI in malignant lesions as well as malignant lymph nodes. So it is very important when it comes to post chemoradiation evaluation to differentiate the fibrotic tissues versus the residual tumors. Those sequences are important. On top of that, and the other sequences such as T1 and the T1 fat set sequences are also very important because we want to differentiate normal fat from the tumor tissues and the tumoral fat. So these fat suppression sequences are also equally important.
Okay.
Again, multiplane imaging, not only the coronal, not only the axial, but the sagittal sequences are also very valuable. You don't get multiplanar imaging in CT unless you get the reconstructions, but MRI, you get multiplanar imaging by default.
Thank you very much. There's another question. We have some more time. Is there any role for MR spectroscopy in rectal cancer?
Well, sir, in my practice, I haven't used, to be frank. Now, when it comes to the brain tumors, yes, to evaluate the metabolic aspect, there is a very good clinical importance, but I'm not really sure about the spectroscopy in colorectal.
Okay, thank you. There are a few minutes more, and I can go for the third question, which has been forwarded to you. Best imaging method in diagnosis, liver metastasis, and the regional nodes in colorectal cancer. What's that? The best?
Yes. For regional lymph nodes, MRI is the best. That is for the mesorectal fat and lateral pelvic walls. But again, when it comes to para-aortic nodes, still the CT is superior because the abdominal MRI not so, there are a lot of artifacts and image distortion due to the gas within the bowel. So para-aortic lymph nodes, still the CT is superior. And when it comes to the liver, CT can detect hypervascular metastasis, and not only that, ultrasound also has a very good value. So in our clinical practice, we usually do the ultrasound scan of the abdomen and the liver first. So especially when there is no fatty infiltration, the focal lesions we can clearly demonstrate ultrasonically. Then we go for CT liver. And in CT livers, we usually see hypodense focal areas as the metastatic deposits. Then when the CT is inconclusive for liver metastasis, either we go for liver MRI or we go for biopsy.
Thank you very much. But you seems to have sort of aroused the interest of the audience so much. There are flow of questions coming. In what interval between the completion of the chemo-RT and the resection of, reassessment MRI you should see that?
We usually wait for 4 to 6 weeks to do the repeat MRI.
Okay, thank you very much. Could you take another question, please? Endoscopic ultrasound and the MRI. What is the difference?
Right. When it comes to T1 disease versus T2, that is involvement of the submucosa and the involvement of the muscularis propria. That differentiation is feasible with endoscopic ultrasound. MRI sometimes, so when you compare endoscopic ultrasound versus MRI, I would say the endoscopic ultrasound is superior to MRI when you differentiate T1 disease from T2. Anything beyond T2, MRI is the best.
It's fine. Thank you very much. It has been very informative for all of us. And thank you very much for your contribution. Thanks a lot.